come. So I welcome you all. I have with me our guest for tonight. Elizabeth Akinde is a principal school of midwifery, Lagos University Teaching Hospital. So I will leave Mrs. Akinde to introduce herself. Then I will also introduce the two other panelists that are here with me, who are nurses who are going to give us the presentation. So I'd like Mrs. Akinde to introduce herself because all our titles are tongue twisting. So I want her to introduce herself properly. Mrs. Akinde, you're welcome. So go on, Mrs. Akinde, and introduce yourself.
Can you hear me?
Yes, I can hear you now. I can hear you now.
Okay, my name is Mrs. Elizabeth Akinde. I'm a midwife educator. I train midwives. I'm a woman's advocate, and my specialty is advanced midwifery and natal nursing science. I'm a cheerleader of mothers. Throughout their fertility journey, I am there cheering them along. For most of us, we have our sex fun, do different styles, but hardly have we get out of bed, already there's the bump and the duckling walk. But for some of us, it is not that quick. Some go through harrowing, humiliating, and emotionally tasking moments to get that bump. In our culture, the hallmark of a woman is bearing children. And the Nigerian woman wants at least 2 children. The topics which we will discuss today are topics which are often not talked about, despite how common they are and how many people will experience them. It is therefore important that we discuss these topics to promote our understanding of them and identify how they affect fertility, as well as ways in which they can be managed. Every one of us here know 1 or 2 women who are looking for the fruit of the womb or looking unto God, as we say in our local parlance. Gbemisola is going to take us through on how we can help these women. At the end of the day, it is our goal that we all live here more knowledgeable that we came. So I employ us to sit down and enjoy the moment.
Thank you so much, Mrs. Akinde. Thank you so much. That's quite interesting. Yes, as nurses, we know that we have people around us. We see them in the hospitals where we work. We see them in our churches. We see them in our environments. You know, if you are knowledgeable, it's easy for us to be able to talk to them, to educate them on what to do. So let me quickly introduce Gbemisola Ojo Adekunle. Gbemisola Ojo Adekunle is she's a nurse. She's a fertility nurse of about 13 years experience. Gbemisola is also our clinic coordinator and also the head of endoscopy units. Gbemisola has a basic knowledge, basic training in obstetric and gynecological ultrasound scan from the Thomas Jefferson University in New York, and also in Philadelphia, sorry. And also she has some knowledge of cosmetic surgery from Pelosi Medical Center, New Jersey in America. Gbemisola has experience in endoscopy, over 4,000 cases that she's, assisted with throughout her experience in Nordica, the journey so far for 13 years. So she's very knowledgeable on infertility matters. She's well knowledgeable on endoscopy matters. So, Gbemisola, you're welcome. So let us hear you. Talk to us about infertility. Talk to us about management of infertility from your experience. Thank you.
evening, everyone. As I've been introduced, my name is Gbemi Solan. Great nurses. Yes, we are nurses and we are great. So this evening, we are going to be discussing unexplained infertility. And I would like all of us to be attentive. Bear with us, this is what COVID has turned us to. And it's even a very good medium because many of us will not have the opportunity to gather because we always have this every year. And it's a very good opportunity for us to listen. So like I said, I'll be talking on unexplained infertility. Using this outline, we are going to define what infertility is and also define what unexplained infertility is. We are going to be looking at the signs involved in pregnancy, what basic investigations are carried out, other investigations, what are we missing out when helping this couple to achieve conception, what is the effect of infertility itself on the couples, what kind of treatment do we give them. As nurses, very, very important, we need to know our roles, and then we conclude. Infertility, as we all know, is the inability of a couple to achieve conception. Now, not just to achieve conception, we can't say a couple that are married for just a month should start running healthcare. No. We say infertility is when they are not able to achieve conception within a year of regular, unprotected sexual intercourse. We won't say somebody is infertile if the person is not having regular intercourse or they are having protected intercourse. So we should bear that in mind. Defining what unexplained infertility is infertility in which a cause is not found after the investigation is done. Once they've done their basic or standard investigation, we still do not know the cause of infertility, and we call it idiopathic infertility. And this kind of infertility occurs in about 10 to 15% of couples with infertility. That means if you have about 100 couples being screened, 10 to 15 of them will have unexplained infertility, while others can have combined factor, female factor, or male factor. Now we are going to take us back while we're in school. We are going to be looking at an overly simplified example of signs involving pregnancy itself. And using this diagram, for example, I'm going to talk us through when the egg is released, fertilization, implantation, and so on. The hormones that stimulate egg development must definitely be made in the brain and pituitary and should be properly released. The egg must also be sufficient, both in quality and should be chromosomally normal. You can see that as a picture of an egg. The egg also must develop to maturity. The brain must release sufficient amounts of LH. That's the hormone that is responsible for the final maturation of the eggs, after which ovulation occurs. And what we mean by ovulation, that's ovarian follicle rupture and release the secondary ovarian cells. After which the fallopian tubes pick up the egg. The sperm then survive their brief visit to the vagina during coitus, enter through the cervical mucus, swim into the fallopian tube, and find the eggs. What happens next? The sperm must be able to go through the cumulus cell around the egg and bind to the shell, which is the outer coverage of the shell, also known as zona pellucida. The sperm also must undergo a biochemical reaction and release their DNA package, meaning they have to have their complete 23 chromosomes. The 23 chromosomes should be released into the eggs. The fertilized eggs now start its journey by dividing, continue to divide day 1, day 2, day 3, day 4, until it gets to blastocyst stage. The embryo must continue to develop normally and expand into what is known as blastocyst. The blastocyst, which is the day 5, must hatch out of its shell. And the endometrial line of the uterus, very, very important, must be receptive, must be ready to receive the embryos also, which is also known as what? Implantation. We are not saying that a weak link anywhere in this theory I've explained causes infertility. From the journey of egg release, egg being released, fertilization taking place, implantation taking place, which is a normal process. Any weak link causes infertility. we are talking about unexplained infertility, we should bear in mind that it can either be primary infertility or secondary infertility. What do I mean by this? Primary infertility means the couple, they've never conceived before. They've never achieved any pregnancy. While secondary infertility, on the other hand, is inability to become pregnant after previous conception. Either they have a live birth or not. Once the woman has conceived before and she's not able to conceive again, that is what we mean by secondary infertility. So in the course of my presentation, I'll be referring to both the primary infertile couple and the secondary infertile couple. What are the basic or standard investigations that we should carry out before we can say somebody has unexplained infertility? The first thing is the SFA, which we all know as seminal fluid analysis. This is when we look at the sperm. We want to know the count, very, very important. Are the sperm cells motile? What is the morphology? That's the shape of the sperm cells. We want to also do the hormone profile. The seminal fluid analysis, for instance, the sample is collected at a particular period of time. Also for ovarian assay, which include the follicle-stimulating hormone, the luteinizing hormone, and prolactin. These are hormones that are responsible also to help us know the woman, to help us know the ovarian reserve. We also look at the AMH as anti-malarial hormone and intrafollicular counts. That one is also seen while carrying out the ultrasound. Very, very important. HSG cannot be overemphasized. These are the basic investigations. But believe you me, these basic standard tests for infertility, they barely scratch the surface. They are looking for obvious factors like blood tubes, when you are doing your HSG, like abnormal sperm counts or ovulation problems. What are we not doing as standard tests? Laparoscopy, for example. What do you mean by laparoscopy? This is a surgical look into the pelvic cavity through small incision on the abdomen to look at the uterus itself. We are looking at the uterus, we are looking at the fallopian tubes, we are looking at the ovaries. Believe you me that by the time you do this test, which are not standard, we find out that there are underlying factors that should also be considered. Another test is hysteroscopy. Unlike the laparoscopy that we go through the abdomen, when doing hysteroscopy, we go through the vagina. A telescope is inserted through the vagina into the cervix to view the endometrial cavity. That is what and things we can see under hysteroscopy are things like polyp. We rule out polyp, we rule out adhesions, Asherman syndrome. We rule out fibroid, all the submucous fibroids. We can identify them using hysteroscopy. We must also look at the sperm DNA integrity assay. Very, very important. Now, while doing all these investigations, what can we be missing out? Endometriosis, for instance, especially if it's mild or even severe with no symptoms. My colleague, Nena, is going to be dealing with this, and she's going to elaborate more on the endometriosis. And if a laparoscopy is not done, how do you want to identify a client with endometriosis? Tuber disease, for instance, peritubar adhesions, femoral problems. HSG is also a good test to be carried out, but sometimes it's not reliable in the sense that it cannot diagnose proximal diseases, for example. Also, we need to also take a look at premature ovarian aging. That talks about the egg quality and quantity. Sometimes what we are looking out for might be as simple as nutritional deficiency. We know the importance of adequate diet, calcium, folic acid, vitamin C, all these be up. Also to mention inaccurate timing of sexual intercourse. A couple will tell you they are trying to achieve pregnancy. They only have sex 2 times in a year, 3 times in a month, and they tell you they are trying to achieve pregnancy. Stress also is a factor to consider. The hormone adrenaline, as we all know, it sends bad signal to the body that the body is not conducive for conception. It inhibits progesterone. It also causes pituitary gland to release high level of prolactin, and this also causes infertility. So we must pay more attention on stress. I'm going to talk more on age. We all know that age affects infertility. Why? As a woman advances in age, her reproductive potential decreases. This is very, very important. When we talk about fertility, we are talking about egg quality. So once egg quality is affected, infertility sets in. The older the woman, the higher the possibility of her producing eggs that are not chromosomally okay. Our ovarian reserve is also diminished. Egg quantity also reduces. We all know that for a woman to go into menopause, it won't just start in a day. How old is the woman? Is she in her 40s? Definitely by the time menopause is setting in, we call something climacteric. It started a few years before that time. So we need to consider this when counseling infertile couple. Also, what is the sperm quality? We should all know that women go into menopause. Definitely men also go into andropause. So as the age of the man also increases, his fertility potential also do what? Decreases. We should bear that in mind. Now, when we are talking about unexplained infertility, it will definitely have impact on the couple. We are going to be looking at the effects this infertility have on couples. Number one is that it's very, very difficult for them to accept that they are infertile. You can imagine they've gone through the normal investigations, they've been certified okay. The man is like, I'm not the problem here. The woman is, I'm also not the problem. So it's difficult for them to accept. So here as nurses, we need to know this. We need to understand that infertile couple, especially the younger ones, we should talk to them better. It's also frustrating to the couple. Family and friend pressure will set in. Have you gone to the right clinic? Have you seen the right doctor? Have they been able to tell you what the problem is? All this is very, very important as nurses. We should know, we should be sympathetic. It's when we are sympathetic, we know what they are going through, we'll be able to help them better. Also, guilt can set in for the woman especially. Is it that I did abortion and I did not disclose to my husband? Is this what is disturbing me? Or am I paying for a wrong I've done years back? Is it because I didn't start having children early? You know, all these questions is going through their mind. A lot of them must have spent their lifetime investment. They must have spent a lot of money. So all this is a guilt that they go through all over and over again. What are the treatments we can give for unexplained infertility? There's a treatment we say wait and see or expectant management. They don't want to wait and continue waiting. Like I mentioned before, age is very, very important. For a couple to say they want to wait, a 40-year-old lady that is lucky to get married at the age of 40 would not say she wants to wait, because we know that as a woman advances in age, her reproductive potentials also decreases. So age is very important when considering the management of waiting. Also, eating nutritious and adequate diet is also important. These are the things we tell our clients. There's a theory we call Mediterranean theory, which is Mediterranean diet rather. Very, very important. What they consume, the kind of food they eat is very, very important. Lifestyle also, for the men, are they smoking? We need to tell them to quit smoking. Are they drinking excessively? They should cut down on their drinking habits also. More exercise, and I think by the time they do this, but this is definitely better for younger couple. But you have to tell them that the longer they wait, the less the chance of achieving conception. Another treatment is ovulation induction and timed intercourse. What do we mean by this? We give drugs like Clomid, but we need to tread on it because Clomid is definitely misused. You see people giving a 40-year-old Clomid. Are they considering a tuber factor? Are they considering the sperm quality? Also, sometimes they give injectables. We also do something we call ovulation induction combined with intrauterine insemination. This is better than ovulation induction with timed intercourse. But we'll tell the couple that once you've done IUI, which is also called intrauterine insemination, about 3 times and it's not working out, you need to take and get advanced method of achieving conception, which is what will take us to IVF. That's a better option of treatments. IVF, also known as in vitro fertilization, is an assisted reproductive technology, which is called ART. It definitely has better higher success rates. The younger the woman, the better the success rate. And also, you know, younger women also have normal ovarian reserve. The process involved in IVF have to do with controlled ovarian hyperstimulation, whereby the woman will be given some medication, especially drugs. When the eggs are matured enough, we retrieve them, we fertilize, then we transfer back the embryo. That's the process of IVF. What IVF definitely gives better clues to the cause of infertility. It will tell us things like low fertilization rates per egg. We can see the sperm quality also. If the sperm quality is not optimal, you might tell them to do a test called DFI. Sometimes we see the rate of development of this embryo. We see if the embryos are abnormal, we see abnormal shells. All these can be seen in IVF compared to ovulation induction with time intercourse, all the rest. Now, we are going to concentrate more on our roles as nurses. Number one, we are closer to these clients. We have them as families, we have them as neighbors, we have them as colleagues, we have them as friends. We are more like their first contact. So the kind of advice we give them is very, very important. As nurses, we need to be knowledgeable enough to give reliable information to this couple. When they come to you, we need to help them to do what? To talk them through this process. It's when we know as nurses, we can give out what we know to others. Number one, we need to disabuse them about the use of Clomid. Clomid, which is now over-the-counter drug. You will see a 40-year-old woman using Clomid. What is it going to do to her? We also need to advise them based on the age. Like I said earlier, considering the age at which the woman is getting married, very, very important. If a 20-year-old, for instance, gets married, I would tell her, okay, you can wait for a year. If you're not achieving pregnancy within a year, you can seek help. But when a almost 39, 38 woman is getting married, you know, the earlier they seek better advice, the better. Also, we are going to look at tuber factor. When considering them to take drugs or when considering them to seek for specialist advice, we want to tell them to do HSG. Once the tubes are blocked, they should not wait. They should seek for help. Also, by the time the man is telling you, I'm having low sperm counts, that's why the sperm parameters are very, very important. When they're having low sperm counts, we don't advise them to wait. Unlike people that, okay, they've done the investigation, they don't know what is happening. But once they know the cause, as nurses, we need to help them. Then we also need to dispel myths like correct misinformation. Okay, my family member have told me I need to go to the herbalist, I need to do, you know, but because I'm also involved in doing hysteroscopy. During this procedure, we see that a lot of them have used herbs, corrosive material, putting into the vagina. Do you understand? And this will definitely cause more problem than good. And also we need to validate their feelings. What do they know? What do they know? What do they understand with the issue they are having? All this we need to put in place as nurses. Also as nurses, our role in assessment is very, very important. What are their worries? What are the concerns? Are they uncertainty about their future? Very, very important. Then by the time we are able to assess the age of the woman, her current state of health, do you understand? We are able to put all this in place. What are the results she has? We can counsel them, we can support them better. And the most important thing as nurses is to do what? Give prompt referral to specialists, which is very, very important. Even in our place of work, you see couples coming 10 times, 5 times, saying gynecologists, they kept doing investigation. They kept telling them to use drugs. As nurses, we are closer to them. Please let us encourage them, let us enlighten them to seek prompt specialist advice. This is very, very important. In conclusion, I would say, when facing unexplained infertility, it is important to cover the basic investigations first. If additional investigations are required, we also do them. Timing intercourse correctly, telling them to eat well and reduce stress, very, very important. Then emotional and psychological aspects cannot be overemphasized. Thank you for listening.
Thank you so much, Amy, Sola. Thank you, thank you, thank you. I also learned one or two things after so many years of fertility management. That was a very good presentation. I will advise that if you have any question, please can you drop your questions so that we can take them at the end of the presentation so that we don't cut ourselves in between. If you have any question for Gbemisola, just put it down. She will answer them at the end of the presentation. Also, let me introduce our next speaker, who is Nnenna Okoro. Nnenna Okoro is going to be talking to us about endometriosis and infertility tonight. Nnenna is a graduate nurse. She's a nurse, she's a midwife. She's a public health nurse. She's also a fertility nurse. Very versatile, very knowledgeable, and very disciplined. So, Nnenna Okoro, over to you. Management of endometriosis and infertility.
Good evening, everyone. My name is Nina, like I've been introduced, and I must say, Nosbemi, thank you for that very wonderful presentation. I've also gleaned some knowledge. Now, what I'll say about endometriosis is that before joining Nordica, I had never heard of endometriosis, and I had been practicing as a nurse for some years, even as a midwife. I'd come in contact with people with gynecological problems, and I had never heard of endometriosis. So we can liken endometriosis to hypertension, which we call the silent killer. Many people are walking around with it, but they never get to diagnose it until they probably slum one day and they are rushed to the hospital, and then a diagnosis of hypertension is made. That's the same way endometriosis goes unnoticed and undiagnosed for most women until they have waited for years, and then when they eventually seek help for their infertility problems, they get to know that they've had endometriosis all this while. So the purpose of this course for us as nurses is that whenever we come in contact with an endometriosis patient, we are able to identify them. That's what we hope to achieve at the end of this presentation, that we are able to identify a person with some of the signs and symptoms and presentations of endometriosis and refer them appropriately. So we'll go right into it. So endometriosis is a condition which affects 1 in every 10 women. I remember when I was in secondary school, I used to see a lot of people that had some of the symptoms that I'm going to be sharing with you, but we never thought much of it. We just thought they were having normal menstrual problems. So 1 in every 10 women of reproductive age between age 15 to 45 suffer from this condition called endometriosis. It's also found more in infertile women than in fertile women. It cannot be prevented, but it can be treated effectively. And like I said earlier, it's highly misdiagnosed. Now, what is endometriosis? Endometriosis is the abnormal growth of endometrial tissues outside of the uterus, especially on the organs of the pelvis. This is to say, tissues that are supposed to be found in the endometrial lining, you find them outside of the uterus. Tissues that are supposed to be found inside of the uterus, you find them in other places. Areas of endometrial tissues found in ectopic locations are called endometrial implants. These organs include ovaries, fallopian tubes, the bladder, and the bowel. So, like I was saying earlier, the endometrial lining that is supposed to be found inside of the uterus, sometimes you find them on the ovaries, sometimes on the fallopian tubes, sometimes on the bladder, other times on the bowel. Now, what causes endometriosis? The cause of endometriosis is not completely known, but some theories have said that retrograde menstruation can cause it. That's when a woman is seeing her period, when she's menstruating. It is said that some of the blood flows back into the tubes and then on the ovaries and into the abdominal cavity, and then they begin to develop. Others have said that cells around the pelvic region have capacity to develop into endometrial tissues. That is to say, cells just begin to grow, just like cancer cells begin to grow and divide abnormally and cause cancer. These cells in the pelvic region just begin to develop outside of the uterus. Other studies have shown that the bloodstream sometimes transports endometrial cells and deposits them in different aspects of the areas of the body, like the lungs, the liver, and the brain. Now, who are some of the people that are at risk of having endometriosis? Endometriosis has been seen to be hereditary. So if a mother or sister has endometriosis, it means that another female in that family is likely to have it. Also, people that had early menarche, that's the had onset of menstruation earlier than 12 years, 8 years, 9 years, 10 years, they are more at risk of developing endometriosis. Then we also have people that have very short menstrual cycles, less than 28 days, are also at risk of having endometriosis. And also people whose menstrual flow lasts more than 7 days. I know somebody in secondary school that used to see her period for almost 2 weeks. So once a person's period lasts for that long, the chances of some deposits being left where they shouldn't be is higher. Now, what is the pathogenesis of endometriosis? How does it develop? The manner of development of endometriosis
Sorry, we are trying to sort out some technical issues. There's a background noise that we're trying to remove. We'll be with you shortly.
Sorry about that. Sorry about that. We tried to sort out some issues and we're back online. Hopefully you had some time to process some of the information that were given earlier. So we'll take it up from pathogenesis of endometriosis. This is the manner of development of endometriosis. It's actually not fully understood, but the most widely accepted proposition is that these endometrial cells are transported from inside of the uterine cavity during menstruation. Now, these cells that are transported become implanted at ectopic sites like on the surface of the uterus, on the ovaries, fallopian tubes, on the broad ligaments, and in very rare cases, on the liver, lungs, and the brain. Now, what happens is whatever is happening inside of the uterine cavity also happens to those cells on all those ectopic sites. So as estrogen is released from the pituitary gland during the follicular phase of the menstrual cycle, they cause follicles to develop, and also they make the endometrial lining thicker in preparation for implantation. Now, this increase in estrogen triggers the release of the luteinizing hormones from the pituitary glands. Luteinizing hormones now cause ovulation. After ovulation, the corpus luteum secretes progesterone, which maintains the thickness of the endometrium in readiness for pregnancy. Remember, as this is happening inside of the uterine cavity, it's also happening on all those sites on the ovaries where the endometrial tissues are found. If there is no pregnancy, the uterine lining begins to break apart and it sheds. This is the process we all know as menstruation. Now, in the uterus, menstruum flows out through the vagina. On the other hand, on all those ectopic sites, that's on the fallopian tube, on the ovaries, on the broad ligaments, there is no outlet. So what happens is that those implants, they bleed into the tissues. Continuous bleeding into the tissues leads to formation of chocolate cysts, which over time forms scars and adhesions. And these become endometriomas. This worsens with every menstrual cycle. Now, what are the stages of endometriosis? We have 4 stages. And after now, I'll be showing us a pictorial example of that. In stage 1, we see few superficial implants. In stage 2, the implants begin to increase in number, and they get deeper into whatever part of the body they've embedded in. And then we see mild scars or adhesions and pain. Stage 3, which is a more advanced stage, we see deeper implants, small cysts on one or both of the ovaries, and also thicker adhesions. Then the severe case, which is stage 4, we see many deep implants, large cysts on one or more of the ovaries, and many dense adhesions, also known as scars. They suffer a lot of pain and heavy menstrual flow. So this is a pictorial description of what I just said. Now we can see the fallopian tube, we can see the ovaries, we can see those little darkish things. They are getting from the left to the right. You can see that the cysts are getting more in number, the implants are getting more in number, and they are getting larger. Now, what are the signs and symptoms of endometriosis? Some of the common symptoms include pain. Endometriosis patients suffer a lot of pain. They have pain when they are seen before they see their period, during their period. Then they have painful sexual intercourse, dyspareunia. Then pain even during bowel movements, especially when they're on their period. It's really painful. They have lower abdominal pain. They have heavy and long menstruation that can last for over a week, also known as menorrhagia. Then even on urination, they also have pain, especially when they're having their periods, and also bloody urine called hematuria. They suffer a lot of mood swings because endometriosis patients, many of them have to be on medications all the time, the hormonal imbalance, so they have a lot of mood swings and depression moments. Then in rare cases where these endometrial implants are found on the brain, in the lungs, you can see them having migraines, chest pain, and in severe cases, they even go as far as coughing out blood, usually more during their period. So you can see some people during their period, they bleed from their navel, or during their period, they have nosebleeds. These are some of the signs that can point towards an endometriosis patient. Now, is there a way to diagnose endometriosis? Yes. The first way is through history taking. So when you talk to a client or a patient and they tell you that their periods are very painful ever since they were young, where they have pain during intercourse, they have pain when they're moving their bowels, to point out that this person could be an endometriosis client. Then pelvic examination, when the gynecologist is doing a digital examination on the pelvis, they can feel those scars that we saw in that picture, those scars and those adhesions. They can feel the cyst, especially in the severe cases when they have developed so much. Then on ultrasound scan, endometriosis also has the endometrial cyst. They also have a kind of appearance on an ultrasound, like we can see in the diagram above. It has you see the chocolate cyst and it has that dome. It can be seen on the ultrasound. Then MRI can also give a detailed imaging of the tissues. And then you see those chocolate cysts and the scars, and it can diagnose endometriosis. But the gold standard for diagnosing endometriosis is the laparoscopy, which my colleague talked about earlier on. We use specialized instruments. Their tiny incisions are made on the abdomen, and then the uterus and all the organs around it are viewed. You can clearly see the adhesions on laparoscopy. You can clearly see the chocolate cyst on laparoscopy. So that's a definitive way of diagnosing endometriosis. Now, how does endometriosis lead to infertility? Like we said, endometriosis is more common in infertile women than in women who have conceived a pregnancy before. However, studies have shown that 70% of women with mild to moderate endometriosis will conceive naturally within 3 years without any treatment. But we define infertility as inability to conceive within a year. So many of them go on for years without knowing that they have a condition that is delaying their conception because it's not been diagnosed. So how exactly does endometriosis cause infertility? Many endometriosis clients have this interest in sexual intercourse because it's always painful. And we know that to achieve pregnancy or conception, there has to be regular sexual intercourse. What is regular sexual intercourse? At least 3 to 4 times a week. But when a patient always has pain during sex, they may go as far as having sex maybe once a month because it's painful. So this can lead to infertility. Also, I have 2 diagrams on the screen. To the left, you see the normal ovary, and to the right, you can see an ovary. The normal ovary, we can see about 4 or 5 antral follicles. What are antral follicles? These are follicles that are recruited in every woman per month. Then as they respond to the hormones secreted by the brain, they begin to grow, and one of them gets released in the process called ovulation. So we see like 4 of them there. But on the other diagram on my right, you can see that that big cyst there is an endometrioma. It has compressed the other antral follicles. Therefore, it does not allow them to respond to the hormones being secreted, and they cannot develop. So there's no ovulation, a process called anovulation. And if there's no ovulation, there cannot be pregnancy because there will be nothing for the sperm to fertilize that will further develop into a pregnancy. Then another thing is that endometrial implants and adhesions can distort the normal pelvic structure. I also have 2 diagrams on the screen. We can see what a normal uterus looks like. The other one is distorted by the cyst, by the scars. So the ovum cannot be transported as it should. It cannot be fertilized where it should be. The uterus has been distorted. It cannot necessarily carry a pregnancy. The ovaries, the blood supply to the ovaries cannot be proper when it's distorted. So they cannot respond to blood supply and function as they should. So all this contributes to delay in conception. Then, in very severe cases of endometriosis, we have something called a frozen pelvis. If you look at the diagram on the screen, you can see that the uterus is stuck to the fallopian tube, is also stuck to the ovary, stuck to the bowel, is stuck to the bladder. So everything is meshed up together. So that uterus and the ovaries and the fallopian tubes cannot perform their normal function, and this can lead to infertility. Now, how do we manage endometriosis? The goal of management of endometriosis is to either relieve symptoms or enhance fertility. But for the purpose of this presentation, because we're talking of infertility, we're going to be focusing on enhancing fertility. Now, hormone therapies can be used like Zoladex and OCPs in a guided protocol, which most specialists can handle. You can use these therapies to treat endometriosis effectively and enhance fertility. The medications are best administered by a fertility specialist using guided protocols. Also, laparoscopy can be used in the management of endometriosis in order to enhance fertility. By this laparoscopy, those specialized instruments, like we said earlier, through the incisions made on the abdomen, are used to loosen up, take out all those scars around the uterus, the fallopian tube, and they can also be used to burn out the endometrial implants and make the uterus ready for conception to occur. Also, fertility interventions like IVF is very effective in the management of endometriosis. Endometriosis causes anovulation, and in IVF, fertility medications are used to promote ovulation. So a woman has more follicles, and in a controlled environment, the eggs are fertilized and implanted, and it's very effective. So a woman can have as many babies as she wants and plan her whole conception and delivery. Also, counseling is very important. When I was discussing the signs and the symptoms, I mentioned that endometriosis clients have a lot of mood swings. They have depression moments. So counseling is very key to them. They feel like they're alone. They feel like they're going through a lot. They need a very strong support system. What is the role of nurses in the management of endometriosis? So I'm going to be talking about two sets of nurses. For the nurses that are in the fertility space and our colleagues who are working as pediatric nurses, nurses in the labor ward, postnatal ward, that are always coming in contact with clients and their relatives. For those, I'll take those in the fertility space first. Proper assessment is very important. If endometriosis is not diagnosed early, it can delay fertility. So proper assessment using the ultrasound scan, using the laparoscopy, nurses play a huge role in guiding clients to go for assessment early enough. And nurses also work hand in hand with the gynecologists, work hand in hand in planning and implementing and evaluating the care of these endometriotic patients. Counseling, like my colleague said, nurses, we are closer to these patients. They may not open up to the doctor, they may not open up to the lab scientist, but they will talk to us. So that's an opportunity to counsel them, to seek help, to support them, and be there for them. Then for nurses in the other fields, we have two main roles. Early diagnosis. So many patients go undiagnosed or misdiagnosed. In fact, we had a client recently that said she was even being treated for cancer because they couldn't understand the condition. She had endometriosis where her lungs used to get filled up with blood when she's on her period. So hers was so severe that she was being treated for cancer, and her family were waiting for her to die until someone introduced her to us, and then endometriosis was diagnosed, and thankfully now she's pregnant and going on with her pregnancy. So early diagnosis is very important in endometriotic clients. Many of them go unnoticed. And then as soon as we may not be able to specifically diagnose that this is endometriosis, but now we know some of the things to look out for: the painful periods, the long periods, short cycles, pain during sex. We know all this. So if we interact with a client and in the process of history taking or conversation, we see or hear some of these symptoms from them, it's important to refer them immediately to a specialist, because timing is very crucial in infertility management, because a woman's fertility declines with age, and the longer we wait, the more difficult it becomes. In conclusion, endometriosis is a common condition affecting women. Yet many, including health practitioners, are unable to identify it. Thus, there is a need for increased awareness, which we hope that this presentation has been able to do. The importance of prompt referral, timely and specialized intervention cannot be overemphasized, especially in infertility management. Thank you so much for listening.
Thank you, our endoslayer, Nena. She's an Yeah, thank you so much. That was a beautiful presentation. Thank you. And to say that before you joined Nordica, you didn't know anything about endometriosis. You've never heard of endometriosis. Now you are a pro. You are an endoslayer, truly. Yeah, that was a good presentation, and thank you. Thank you for everyone that's listening. Some people have dropped their questions. There is one important thing that I picked from what Nena said. She said endometriosis is highly misdiagnosed, and that's the truth. She has seen a client that is being treated for cancer. I have seen one that's been treated for tuberculosis, and we got to know that she had endometriosis eventually. So we have some questions here that I want to pick, and there's so many of them. So I'll just direct some of the questions to whoever is going to answer them. Ms. Akinde, before we go on to questions, maybe you want to say a few things about the presentation from Bemi and from Nena. We need to unmute you, sorry. Okay.
Thank you very much, Gbemisola and Nena. Gbemisola is our main guy. Gbemi, you're doing us proud, though.
Thank
Grace
you.
Nurses. So you really tried, and this is also talking to us that you can specialize as a fertility nurse. So you don't end at midwife, A and E, this one. There's another area of specialization called fertility nursing. So these two ladies that spoke to us this evening, they are fertility nurses. So you can specialize in fertility nursing. And then Gbemisola, infertility is very difficult to, unexplained is very difficult to manage. And it's very difficult for the woman to come in. So this is where our strength comes. You encourage her to go, because she's the one that will tell you, I've done this, I've done this, I've done this, I've done this, and nothing is coming. So she's the one that we really have to encourage, give her a shoulder, and then direct her like our fertility nurses have told us. Also, you can pick them when you will see a woman holding a 5-year-old maybe coming for immunization. And in the course of talking to you, you will find out that she will tell you that she wants another one, but it's not coming. You catch them from there and then encourage her, and then try to help overcome the stigma. There's a kind of shame, or I can't do what others are doing, that some of them want to exhibit. So it is our responsibility to help them, to help them know that, no, there is nothing that you're doing wrong. All you need to do is to see a specialist, and then we direct them to the right person. So thank you, Bemi. Thank you, Nena. You're really doing us proud.
Thank you so much, Mr. Akinde. Thank you. You've said a lot of things to our nurses out there, because we have opportunity to meet some of these people when they come to the clinic for one thing or the other, and we can advise them. Some of the questions here also is going to focus on the advice that we can give to them, because I've seen some of them. Yeah, one question Linda is asking, Bemi, she said, age 45 for men, because she said because she has seen men giving birth at 70. So when you talked about age 45, for andropause, for men, that's what are you going to talk about that? Because men of 70 years have given birth. Yes, I know that my father also gave birth at that age. So what are you going to talk about that when you mentioned age 45 as andropause age?
Yes, in the course of my presentation, I mentioned that men also go into andropause. Just like women, as they advance in age, their fertility potential decreases. That doesn't mean a 40-year-old woman cannot conceive naturally. So as the age of the man increases, the sperm count might be okay, but the quality of the sperm is very, very important. What is the integrity of those sperms? We need to know the DNA fragmentation. We do a procedure like that, a test like that. We need to know the quality of this man. Eventually, if the man gives birth to a child or impregnates a woman and she gives birth, is that child, we are looking at IQ, IQ setting in, their mental developmental, these things setting in. So we're not saying a 70-year-old cannot impregnate a woman. Yes, he can. But we should know that age of the man is also important. We should not just concentrate on the woman alone. That is very, very important.
Thank you. She also asked a question that, does the quality of life of women diagnosed with infertility affect their chances of achieving pregnancy? Quality of life for women diagnosed with infertility.
Quality of life. Take, for example, a woman that smokes, a woman that consumes excessive alcohol. That's a lifestyle. And compared to a woman, this thing, that's why you say unknown infertility. We don't really know the cause, but there are some predisposing factors that can predispose the woman to not achieving conception. So for a woman to have issue with conceiving, she needs to put a life balance. That is very, very important. So quality of life is very, very important.
So part of, I also, we add that quality of life, lifestyle can make you to be obese, and we know that obesity is also a factor in fertility. So Linda also asked a question that if a couple wants to do sex selection, is it still IVF that the couple will do?
Yes, sex selection can either be done through IVF, or we also can do there's one that is very new, we call it NIPT, whereby the woman is pregnant to take maternal blood sample to check the sex of the baby. But for you to do this, that means you have to wait to about 10 weeks pregnancy for us to do this test. But IVF is still the basic, it's more precise. The chances of you achieving your desired sex is better with IVF.
Okay. Caroline Odele from Facebook is asking, what will you say about donor eggs? That's just the question. What will you say about donor eggs?
Donor egg is very good. A woman that is advanced in age, a woman that has gone into menopause, we cannot tell her that she can't conceive again. She's desirous of pregnancy. She wants to have a child. So donor egg, I would say, if someone needs blood transfusion, that's the way I say it. It's something that you need. So its acceptance is very, very important, and donor egg is very good.
So what you are saying is that if that's your only option and you desire to have a child,
definitely there's an option for you.
Because the way I counsel people is, you need a child, it's your desire. So if you are going to use donor egg and that's your only option, then you take it. Because if you compare using donor egg to adoption, which one will you rather have? You are carrying the pregnancy, you are breastfeeding, you have your child. It's not that you are going to be telling everybody on the road that you use donor egg, but that you are a mother, you are carrying the pregnancy, you are breastfeeding a child, is very, very important. And that's the effect that it will have on you when you eventually have your child. Also, another question here, Onyye Okeke says, there are some of these couples who will come telling you how many failed IVF you've had. You see that they're already frustrated. Please, how can we advise them considering the amount spent so far?
Here in our environment, money is involved. We need to tell them it's not over until it's over. And the more they try, the better the opportunity of achieving the desired goal. So IVF is definitely not 100%. So we need to tell them to keep the hope high. They need to keep trying. They need to keep trying. One day they are going to have their desired goal.
As a fertility counselor, I see a lot of these clients. And you know what? The important thing is for you to tell them that it might just be the next attempt.
Definitely.
We've seen people who have done 4 cycles, 5 cycles, 16 cycles. I know of a woman who did 16 cycles. It was on the 16th attempt that she had a set of twins, and she came back again, had another set of twins, making 4. So imagine if she had stopped at 15, she will not be called a mother today. So money is one thing, desire to have a child is another thing. So sometimes you need to put the monetary aspects, to a side and do what you need to do. But it's also important to know that your chances are better when you continue to try. When you continue to try. There is an anonymous attendee here. She says, "Good day, Mrs. Bemisola. I've been married over a year and trying to conceive. I've done hormonal tests, SFA for my husband, HSG. I was induced for ovulation for months with metformin, tamoxifen, and steroids. Though I have fibroid about 7 cm, 7 with different sizes. The biggest is 6 cm. What will you advise, ma'am?"
I would advise you to see a specialist. You should not just continue to see anybody. They will keep prescribing medications for you, and your age is very, very important. Take, for instance, you have fibroids. You want to know the location of those fibroids. Are they inside the womb, inside the endometrial cavity? Definitely pregnancy cannot set in. Your husband's sperm parameters, if they are low, you need to do IVF. So you need to see a specialist that will run the basic investigations on you. Is with the result of this investigation, they'll be able to tailor your treatment to suit you better.
Like for Nena here, patients with endometriosis who have normal menstrual flow. Is the consistency of the menstrual flow normal? That's from Epsiba.
Sorry, I didn't get the question.
She says, do patients with endometriosis have normal menstrual flow? Is the consistency of the menstrual flow normal?
Yes, to diagnose endometriosis, we cannot use only one thing. So it's possible that a patient with endometriosis would have normal menstrual flow, but then have some of the other symptoms. That's why it's a condition. The person needs to have 2, 3, or more of those symptoms and then run the test to be able to say, okay, they have endometriosis. So yes, it's possible to have normal menstrual flow and still have endometriosis.
Okay. But also, the consistency of the menstrual flow, is it normal? Do they have normal flow?
They majorly have heavy flows. Heavy and longer flows.
And longer flows, yeah. Okay. Someone is asking, is surrogacy allowed? From Margaret Babalola, is surrogacy allowed? Maybe Sola, you want to answer that?
Yes, most importantly, if the woman has endometriosis, while Inanna was presenting, she showed us a picture of a frozen pelvis, for instance. The uterus is distorted. Even if she's young, she can't carry pregnancy. So surrogacy is allowed.
And not only in the endometriosis, maybe
surrogacy is allowed, yes.
There are other reasons why surrogacy. Someone uterus has been removed. The only way to have a child is through surrogacy. So surrogacy is allowed, and it's here with us. It's something that we do here in Nigeria now. Someone says, "Thank you for the presentation. Please throw more light on the carcinogenic side effects of the drugs for IVF."
Yes, for IVF, for any woman to do IVF, number one, because we know that it's not been proven that it causes cancer to start with. And there are other predisposing factors to cancer. So before a woman does IVF, we also examine her to be sure she doesn't have those predisposing factors to cancer, that the drugs can lead to cancer. So this is very, very important. But IVF drugs will not cause cancer.
Okay. Someone says, "Thank you very much. My question is that women that menstruate, can we suspect endometriosis? I don't know what that means. Nena?
The question is not clear. Every woman menstruates. So we may need to define, the person asking may need to define the specific thing she wants to ask. Almost every woman menstruates. It's part of the normal cycle of a woman.
So we can't just use menstrual cycle to diagnose endometriosis. That's what you're saying.
Yes, ma. Not just, it's a couple of symptoms put together as well as laparoscopy. Like I said, that's the gold standard for diagnosing endometriosis.
Okay. Someone says, can a woman that have IVF with donor eggs breastfeed? I think I mentioned that. Yes, you can. When you are pregnant, you can breastfeed. You'll be able to breastfeed, yeah, unless there are other reasons why you cannot breastfeed. But if you are pregnant, you can breastfeed. Yes, you will breastfeed. Let me see again, which other question? Thank you very much. Okay. Someone says, thank you very much for this lecture. I really enjoyed it. I have a client friend who is suffering from endometriosis. I've even traveled outside the country for this. After a series of these injections, Zoladex, still having the pains. Please, why? And what's next advice to her? Thank you.
We'll advise her to see, it's not enough to take medications. It's better to see a specialist who will properly diagnose her condition and tailor the treatment and management to her. So it's not enough to just take medication. She needs to see a specialist. There's a protocol for managing endometriosis, and that lies with specialists. So she needs to see a specialist as soon as possible, because endometriosis is a progressive disease.
Thank you. Someone says, can we have the slides or recorded copy of this educative teaching? Yes, we have it on Facebook and also on our YouTube page. So Nordica Facebook page. So if you go on Facebook, you log on to or like the page, Nordica Fertility Centre. We are transmitting live there also. And it will be uploaded on our YouTube channel also for you to be able to see them after. Which other question can we go through? Can someone with HIV go for IVF? Bemisola?
Definitely yes. HIV is not life. It's not life sentence. It's not death sentence. Somebody for HIV can go for IVF.
Okay. Is surrogacy allowed in Nigeria?
Surrogacy is welcomed, not just allowed. It's welcomed. It's something we do in Nigeria.
Okay. Someone also says a 40-year-old woman complained that she has not been seeing her menses since 2 years. She has done tests to rule out infection, but it came negative. What is the solution to Bemisola? 40-year-old woman who has not seen her menses for 2 years.
We call something premature ovarian failure. I've seen a 35-year-old lady that stops menstruating. So, yes. So it's possible that she's gone into menopause, but she needs to see a gynecologist, she needs to see specialists, she needs to carry out investigations to be sure she's not having other underlying issues. Very, very important. So it's possible for a 40-year-old to not see her period again.
And one thing that I also notice is that a lot of people just go for tests. Age is not on the side. They continue to wait. That's why we are talking about unexplained infertility. You don't have to wait before you take action, because the age of the woman is increasing, your chances is decreasing. So don't wait until you are 40. Don't wait until you are 45 before you decide to do IVF. Once you're married and pregnancy is not forthcoming, and you've done all the necessary tests. For instance, someone who has not seen menses, I don't know why somebody will be looking for infection. Do you understand? I don't know why somebody will be looking for infection in that type of person. So you need to take a giant step to do what is necessary. And this is where we come in as nurses to educate our people not to wait for so long. You are married 1 year and nothing is happening, then please seek medical advice from specialists. And if you are more than 5 years, don't wait for a year. And let me see if I have, thank you for the presentation. When Zoladex is used for treatment of endometriosis, how soon after discontinuation would a period return? And how do you get her pregnant without IVF? Nena. Nena, can you unmute yourself?
Okay, Zoladex has a period that it lasts in the body, depending on the one used, some 28 days. Okay, so once that period elapses, the cycle of the person returns and person, and how can we get a client pregnant? That's why we've been mentioning specialists since we started the presentation. We have, like in Nordica, we have a protocol we use to manage endometriosis clients. It's a detailed and effective protocol. And I'm sure that other clinics also have such. So it's important to see the specialist. And I can tell you it's quite effective, and a woman can get pregnant as many times as she's willing to carry. So it's important to see a specialist.
And I also remember that in your presentation, you mentioned the types of, the stages of endometriosis. You know, the mild, the moderate, and the severe. You know, if you have severe endometriosis, don't wait to say you want to get pregnant on your own. You want to get pregnant on your own, don't wait. Because with severe endometriosis, like you have mentioned, you have shown us the pictures of how severe it can be. You need help. So that question that says, how do you get her pregnant? You may be wasting time. You may be wasting time. So it's important for you to see a specialist. Someone said, when are we having the next session? Very soon. We'll communicate. Now that COVID has taught us that this is the way to go. You know, today I had a wedding, you know, online. Yesterday I had a graduation online, and I think it's very, very, it's sweet. We're not spending money again. So, so don't worry, we'll soon let you know when the next session will be. Can HIV male patients donate sperm to a partner who is HIV negative? Maybe Sola, you want to answer that? HIV male patients donate sperm to a partner who is HIV negative. Maybe Sola, can you unmute?
HIV AIDS, we do something we call sperm washing. Sperm washing, whereby we remove the virus from the sperm, because what the men produce is semen. So we do sperm washing so that we have the pure sperm cells. But it's not 100% proven that there cannot be contamination. So for the couple or the partner that is receiving the donated sperm, there should be something we call informed consent. You should be able to know that it's not 100% proven that if I get the sperm cells, my unborn children or unborn child or myself will not be infected, but it can be used. Sorry, I didn't get that.
Can a woman of age 45 go for IVF? And someone also says, do you prescribe, do you advise a routine hysteroscopy for couples going for IVF? So maybe you should take the two together, going Sola.
A woman of 45, a woman of 50, 55 can go for IVF. But once the woman is above 45, a physician must certify her fit to carry pregnancy. We know that as the woman advances in age, her strength is also very, very important. So she needs to be certified fit. She carries out a general physical examination and runs some tests, even including chest x-ray, mammogram, series of investigation to certify that, coupled with her age, she's not going to be affected while she's pregnant. Then another thing, to do hysteroscopy routinely, I would say no, because there's a procedure we call sonohysterogram, whereby fluid is instilled into the cavity of the uterus to see how distensible it is. So if you are going for IVF, that should suffice. That should be able to tell if the uterine cavity is okay or not. It's when there's an issue with that, you can now refer the person to go and do hysteroscopy.
So a woman of 45 can do IVF, and hysteroscopy is not routine. It's only when it is necessary. When it is necessary. Yeah. Someone says she's thanks to all the organizers of this program. I'm a lover of fertility nursing, and by God's grace, I now work in such setting. Meeting nurses who are beautiful and bringing in fertility is hope and joy for me. I have 2 questions. One of the issues I've observed with the issue of fertility is lack of finance. What role can we play in order to subsidize treatment? Then she says, what can fertility nurses do independently aside counseling? If there is, what training are available for this? Demisola.
The first question, subsidizing IVF. You know, definitely IVF is expensive, and buying the drug is not subsidized. So we need to be careful when we say we are subsidizing IVF, because do we want to subsidize and reduce standard? That is very, very important. As much as possible, we encourage couple to get financial help from banks. We have some NGOs, non-governmental organizations. We have fertility advocates initiative, for instance, that help to pay part of their bill. So these are options that they can get.
Okay. Thank you so much. Yeah, she said, what can fertility nurse do independently aside counseling? If there is, what training are available for this? You know, when I was introducing them, so I told you that she's had some training in gynecological ultrasound scanning. So Bemisola scanned very well. So you as a fertility nurse, you can also specialize in scans. You do scans for your client. You know, so it's not just about counseling. You can do other things. Yes, can we make a certificate available for participants? Yes, I think so. If you have your email, if you have sent your email, if you registered earlier on, I think that will be sent to you. What again? I think that's about all. Someone says, Tolu Shangowanwa says, a 49-year-old sees her menses after 1 year and bleeds for 4 days, twice a month. Is it normal? 49-year-old sees her menses after 1 year and bleeds for 4 days and twice a month. Is it normal? Well, you see, there is perimenopause and there is menopause. So if she has not reached menopause, she has not reached menopause. So she can still bleed. But if bleeding is abnormal, I think it's best to see a doctor. At 49, it may be perimenopausal. It may be perimenopausal. So it may be normal and it may be abnormal. Because when you have reached menopause and you see your period, I think it's better to see a doctor, to see a gynecologist for evaluation. Let me see. Yes, there's one thing also that keeps coming to my head when we talk about management of unexplained infertility. In Nigeria, we have abused Clomid. Sometimes nurses even encourage patients to abuse Clomid because we tell them, go and take Clomid. Why do we take Clomid? What do we want to achieve with Clomid? If you know that you want to achieve something with Clomid, have you asked some basic questions? Because when a woman releases an egg during ovulation, it doesn't end there. The tubes, are they patent? Have you asked that question? So if a woman is taking Clomid and she has not done HSG, she might be taking Clomid as if she's taking multivit. So you need to ascertain that tubes are patent before one can take Clomid. And also, as the husband also checked the semen analysis, has he checked the sperm? How good are the sperm? Because if you are taking Clomid and the woman is ovulating and her tubes are patent and the sperms are not good, they cannot move, then how do you achieve pregnancy? So we need to understand all these things so that when we're educating our patients, someone comes to you to say, I've been taking Clomid for the past 3 months. The next question is, have you done HSG? Did your husband do semen test? These are basic questions that we need to ask them. And if you are not taking anything out of this tonight, I think that's one important information. Mrs. Akinde, I don't know whether you have anything to add to what we have. Please unmute. Anything that you want to add to what we have said, so that we can round up.
Thank you so much. Thank you very much, the presenters, and thank you, our audience. But there's one question that kept on popping up. Some of them were asking that where would they get training as a fertility nurse? Another person said, is council aware? What I want to tell them is that a training as a fertility nurse in our country for now has not been totally embraced because the facility to do the practical components, the clinical component of the facility, of the training, is not yet, I think it's only Nordica that is nurses friendly as of now, that try to educate us, try to put us in the picture. And I know that University of Port Harcourt, and then there was a time we are trying to see if we can add fertility nursing as part of midwifery like we did for family planning. But all those things are in the pipeline. For now, it's only Nordica that is midwife friendly, nurses friendly. So let us take from this their lecture and learn from there. If you want to specialize in fertility nursing, you can, I think it's outside the country. I know South Africa and then in the US, you can specialize. I hope we have gained more and our orientation have changed from these two ladies and from what we have learned. I hope you will put it into use, and it has made us more knowledgeable. So all my students, all my colleagues, all my friends that joined this meeting, I want to say thank you very much. Thank you very much. Thank you. And I want to say, Nordica, thank you so much for being nurse friendly. Thank you so much for being so concerned with the education of nurses and all that. I want to say thank you. Great nurses say great Nordica. Thank you so much.
Thank you so much, Mr. Akinde. We're so grateful. Thank you. Thank you for all the people that joined us today. Fuluke Opanide says thank you so much on the explanation on abuse of Clomid. I'm blessed. Thank you so much. Rashida Adigun, thank you for joining. Efziba, thank you. Tolu, thank you. Thank you, everyone. I cannot mention everyone's name, but I'm saying thank you. Thank you, Bemi, for the nice presentation. Thank you for the knowledge shared tonight. And Nena, thank you so much for giving us information. And I believe that the people who have listened tonight have gained one or two things from what we have shared today. So we're running up. And I want to say that COVID-19 is here with us. Let us stay safe. Wear your mask when you are not in your house. maintain social distancing, wash your hands frequently, and stay safe. Thank you, and see you next time. Bye.